Yes,
Yeah,
yes.
thank you so much. So after listening to carbohydrates, I think we are moving to next important macronutrients, which is proteins. It may not be very much relevant to a diabetic population, but we cannot ignore the fact that we have chunk of patients who are diabetic nephropathy. We have patients who are into getting into stage 1, stage 2 CKD. So when we talk about CKD, a chronic kidney disease, the goal of nutrition there and as a dietitian, I think is first to give nourishment. As a dietitian, nutritionist, the whole goal always should be nourishment. And after nourishment, I think we get into the medical nutrition therapy of that specific diseases. So likewise, in CKD also, we'll talk about PEM. We want to assess, prevent, screen. We want to look at all the electrolyte and mineral imbalance. What the diet and nutrition can do in CKD is it can slow the progress of the disease and handle the comorbidities likewise, like diabetes, blood pressure, dyslipidemia, anemia, so on and so forth. And that is why it's very important in CKD from day one when the patient is being diagnosed, either at a diabetologist clinic or at a nephrologist clinic, to give him education. First step is always giving a good nutrition education. And the education should be more of preventing protein energy wasting. Because that's the first thing which we will see in these CKD patients. The challenges are many. The prognosis of CKD is not very great, we all of us know. But at the same time, when we diagnose CKD, we should know what is the root cause causing CKD. Is it a comorbidity like diabetes or blood pressure or any microvascular changes? Is it any kind of loss of kidney function, glomerular nephrosclerosis? So all this, any kind of causes, final outcome, I think, is a poor nutrient intake. A list of don'ts is so much for these patients that they start wondering what to eat. I'm sure all the dietitians who are listening will say, every patient comes to us and say, kya nahi khana hai mat boliye, kya khana hai boliye. And I think that's where our role comes. The first step is look at the screening part to prevent protein energy wasting. And once we are on that particular path, I think we are doing a good job with patient's nutrition, keeping his mentees in mind. So each one of us as a dietitian definitely has a nutrition care process to give to every patient we handle, maybe a CKD, a diabetic, or obesity, any kind of disease management. And that's why it's important to screen, monitor, evaluate, diagnose, nutrition diagnosis, and finally give a diet plan. So the first thing when we look at the diet plan is the energy intake. My whole goal is to keep his BMI normal. My goal is to avoid muscle wasting. First, assess, screen his present intake, his parameters. Very importantly, for this, I think the subjective global assessment form tells us his appetite. In a CKD patient, or in any patient for that matter, taking a recall of his appetite and present intake is very important to highlight the energy intake which we would like to give to the patient. So step one is always looking at the energy, because that's what technically we've been taught in our college days, that energy has to be first calculated, and there are various ways of calculating energy. But what in energy is important is protein and non-protein calories. Because we want the non-protein calories to spare proteins, because the whole challenge is the muscle loss, the PEW. Let's take a case scenario, friends, where we have a typical CKD patient with a 20 BMI, normal, and his present intake, appetite good, but fear of not eating a lot of foods has given his diet recall, as you can see, a typical Indian diet, a chai chapati in the morning, half roti and bhaji, half bowl of rice with some dal or protein or egg, a snack like murmura for evening, a dinner half bhakri or roti with bhaji, the sabji or dal rice, and controlled water intake. Patient is confused. He's been asked not to eat proteins. So there's a lot of calculation behind the scene to learn what to eat. He's a typical vegetarian or a vegetarian patient, for example, we can look at it. So the calculated nutrition is not very great. It is 1200 kilocalories and a 30-gram protein diet. The 30-gram includes the vegetable protein as well as the non-veg protein. And a typical diet chart, if a BMI is normal, can be a 1800, 1700, 2100, depends on the patient's physical activity. And out of that 1800, my first goal is to look at protein calories. I have to restrict protein. We'll talk about it as we go ahead. So the goal can be less than 10% of the total calories. Proteins can be less than 10%, or for that matter, 0.6 to 0.8 gram per kg body weight. If you look at the calculation, it almost comes to the same. Less than 10% of 1800 kilocalorie is nothing but 45 grams daily. And if I go by 0.6 to 0.8, it is also almost the same, 45 to 48 grams. We chart a diet plan to the patient, giving the timings and the meals. We calculate other areas of CKD diet with sodium, potassium, phosphates. But what I forget to look at is personalized nutrition. Very well said by previous speakers. Today's era of nutrition is personalized nutrition. Shilpa started from talking about how personalized glycemic variability helps in carbohydrate management. Dr. Jagmeet Madam talked about generic to specific. So it talks about a personalized approach. There is a lot to talk about when it comes to protein restriction in a CKD. It is established in many experimental animal studies. And in humans also, it's been promoted, and there's an evidence to say LPD retards progression of CKD, because that's what a diet does in CKD. But let's understand an individual approach towards every patient which we are looking and see present nutritional status of the patient, and then work on the protein calculation. We have to usher ourselves into personalized nutrition. Because the LPD, the low protein diet, started with Brenner's hypothesis, where the flowchart tells us that if there is an unrestricted protein intake, which is generally a 15 to 20% of total calories, in an Indian population, very difficult to reach that 15 to 20%, but that's the Western literature which tells us that unrestricted protein intake, it definitely builds pressure on functioning of nephrons. And definitely we know that the glomerular capillary activity pressure, it increases. It increases the GFR, and hence you have a glomerulosclerosis. So these are hemodynamic changes which is happening because my nitrogen content in the food has increased. So definitely more pressure on my functioning nephrons, which are already into a stressed way where they are not able to function well due to any kind of a background prognosis which has been happening. So this was the hypothesis and the theory, but the limitations to that theory was they use creatinine, which I think today we're not looking at it. They use creatinine to plot with time to plot the patient. So all these inappropriate parameters to not really take us to that conclusion of LPD works for CKD. So then MDRD, that is modified diet of renal disease study, came up, where they had grouped the patient into two, study A and study B group. Study A was 585 participants, where the GFR was 25 to 55 ml per minute. Protein intake was tailor-made, 1.38 or 0.58 as per the energy intake. Study B had half the patient almost. GFR was much lower. So the protein intake was much brought down to 0.58 to 0.28, but with 2.28 or 0.3 grams protein is a very low protein, so that's why keto analogs were given. This study did not carry diabetics. So the conclusion of this study was they were slowing, or there was some slowing in the rate of decline in GFR in group A, But in group B, there was no slowing of GFR. So that suggested, yes, LPD diet works to avoid or to prevent the progress of disease. So this time and GFR graph tells us that a low protein diet supports the active progress of CKD. This same concept was done in various studies in India also, because very important is to look at the dietary pattern of that particular area where the studies were done. And we have, fortunately, a lot of studies done in India also. And most of the studies in India do not give any kind of statistical significance with this approach of a low protein diet in creatinine clearance value. So let's understand what must have happened in an Indian scenario. This is an EAA profile from our ICMR FAO guidelines, where we know that to give 1 gram of good quality protein, I need to have a good profile of essential amino acids. And this 20 essential amino acids which I'm looking, and I know that the leucine, 39 mg per kg per day, the lysine, the isoleucine, the branched amino acids, all of them contribute to a significant approach towards a good amino acid profile in my food. India is predominantly a carb-eating diet, as we've been hearing in previous sessions. And we all know that carbohydrate lacks the limiting amino acid as lysine. And when you look at this amino acid profile, you will see the contribution of lysine and leucine and valine, which is a branched amino acid, is highest in good quality 1 gram protein. And in Indian Marketing Research Bureau studies, recent 2017, which have studied the protein intake across the Indian population, observed that 60% of the protein in Indian diets come from cereals. And we all know now the cereals have a limiting amino acid, which is actually lysine, which is contributing more towards your amino acid profile. 91% of vegetarians, 85% of non-vegetarians, all are protein deficit. And anyway, 10 to 12% of the total calories are derived from proteins. So the education begins from complementing in an Indian diet to understand the complete profile of good quality proteins or essential amino acids in my diet. If I have a dal rice or rice dal combination, I have to understand the ratio of rice dal to help me to make up to the limiting amino acid lysine, isoleucine, and leucine. These 3 very important amino acids are limiting in my carbs. I have to complement it with lentils to make it into a good profile amino acids. If you look at an Indian way of eating, it is fantastically tailor-made to a limiting amino acid complementing each other, where you have a good meal. We don't eat a one-dish meal. We have rice, dal, we have sabjis, we have sprouts, we have dahi chawal also at the end of the meal. So I think when we all are listening, and if I'm able to sensitize you, as a dietitian, it's a challenge for us to plan a diet, to give a prescription, to give an MNT, with lot of challenges of do's and don'ts, and nourish my patient. Because my whole goal is not to make the patient malnourished. When my Indian population is itself eating 10 to 12% of protein, not able to complement amino acids, which my body needs it for a good quality protein, am I giving lot of malnutrition to my renal patients? A very good study done by our own colleague Dhamrut Patel and Dr. Bharat Shah, which has been stated in a paper, where they studied their own patients of 560 members in different CKD diseases, and they have looked at their BMI, because BMI tells us their calorie intake, their energy status. So we had a very good BMI till stage 3, 28, 28. And if you look at the graph, at stage 5, the BMI started declining. So when you are not eating adequately, when you're losing weight, do we really have to push lot of low protein as a approach is where we dietitians and medical experts have to understand. So let's take back the case which we started with 20 BMI. So after listening to all this, how would a renal diet be to him when I prescribe? I calculate his protein as 45. And what do I do out of this 45 is give 50% of this 45 gram protein as a good quality first class protein and create an exchange list for my patient saying out of this 45, you need to eat 20 grams of protein or 22 grams of protein, which comes from the best source of protein. So create an exchange list that itna milk piyoge to itna protein, itna egg, itna paneer, itna. Make him understand the calculations about the exchange list as we've heard about carbohydrates. It's time we create a 10 gram, 5 gram exchange list. Give him an allowance saying that isme se koi bhi 20 grams utha ke aap din mein le sakte ho. This is educating your patient and looking at 50% of the protein is coming from a good quality protein. So we can modify his diet, increase his calories by adding more carbohydrates. He's not diabetic, so we don't really have to worry about the carbohydrate or the glycemic load of the meal. So then I look at his diet as adding a milk 150 ml, adding an egg or curd, another HBV protein, and dinner also curd or an egg, whatever is important here as per the protein requirement. So friends, I think the message is clear. Protein calculation less than 30% LPD accepted. Out of that 50% should be HBV to complement for the best amino acid score. So create a list of protein exchanges where you tell your patients that if you're allowed 40 grams of protein, out of that 20 comes from a HBV. So then this is the allowance which you see on the screen because 300 ml milk is 10 grams, 3 egg whites is 10 grams, 50 gram protein is 8 to 9 grams, and a non-veg is almost a 10 gram protein or 50 gram. It's important that we quantify this, tell him the exchanges, so we give him the best of quality protein, which I'm looking at. And likewise, for other stages, and especially even in dialysis, where I'm looking at, or a post-transplant, where I'm looking at a very good quality protein, a high protein, 50% of my protein has to come from a good score. Because it's important, we are changing our definition from PREDICAS, which we were all talking about, protein digestibility amino acid score, to a DIAS. Now, DIAS talks about the amino acid digestibility, not the protein digestibility. It's important to know that in my protein, whatever I'm eating, what is the contribution of the good quality or essential amino acid profile. And this is what we will look at to prevent malnutrition or protein energy wasting. Because if you look at current guidelines, the current guidelines also say as an EAR 0.6 gram per kg per day for a male and a female adult. So are we really restricting protein less than 0.6 for a renal patient? Because LPD says 0.6 gram per kg per day. And that's why I leave all of you with a thinking process that if I am calculating proteins, do I talk about not eating the proteins, or do I talk about giving an option to the patient where he tries to work with a good exchange list of protein, good exchange list of carbohydrates? It will take time, but that to counsel your patient. But I think that's what a dietitian's job is, to educate, to give literacy, as Dr. Madan Madam always says. I hope I have been able to convince you about the way the protein in your diet should be managed in a CKD. Thank you very much for patient hearing, and definitely we'll be taking questions at the end of the session from you. Thank you, Rima. Over to you.